Hello, and today we're in clinic with Emily, and this case is going to be an interesting one as we've got a two-part case where first of all we're going to assess, make a treatment plan, and then remove some unwanted filler, and then in the second session we're going to look at a treatment plan targeting multiple facial zones. So let's get started first of all by introducing Emily, our patient.
Hi. Thank
you for joining us today. Maybe the best place to start is if you could just imagine that we were in the clinic together, just me and you. What would be your objectives for having any treatment?
So my overall objective is just to look naturally reasonably younger, to target some sagging around here, some loss of volume around here, and generally just fine lines around the mouth and around the eyes.
Perfect. We've done all the medical history, we've done all the consent process, we've taken some photos, you can see a before and after our case. So our patient is asking us for a general rejuvenation, general restoration type treatments. So that gives us an open canvas for thinking about which treatments we can look at, and more importantly in this case, maybe how we could sequence it, given that we've had maybe up to 10 years of treatments in the past. And often what we see is that patients over time will notice that they don't seem to change so much, but the treatments they have changed, and filler that can accumulate over the years can often create unwanted distortions that are sometimes hard to perceive as the patient. And so our job as clinicians is then to try and identify where we think maybe potentially filler has displaced over time. And there are a few key areas which are quite prone to this. So this case will be quite good at looking into how we can address that, almost starting afresh so we can then build on a new treatment plan.
Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics. They will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like.
So let's take a look at Emily's face together. So Emily has just told me that she has turned 53 recently, and I would personally say that Emily looks well for her age. And this is obviously, I think, because she's been having treatments over the years, but also fundamentally, Emily has good features, good bone structure. And there is a systematic way in which we can look at the face. And I'm going to start going into more detail on this in her second treatment when we actually outline a treatment plan. The thing that I want to call out for today's session is where we think there has been elements of displacement of filler over the years. And there's three characteristic areas that I'm going to be running through today. So the first one is if we start with the highly mobile zones of the face. And these zones are the orbicularis oculi muscle and the orbicularis oris muscle. And the orbicularis oculi muscle is the most active zone of the face, and it's because we are blinking and moving our eyes so many times throughout the day. The orbicularis oris is second to that, where we have an enormous amount of movement. The lips are extremely dynamic. And so because of all this movement, these two zones are prone for filler displacement over time. But that's not to say that it will just happen automatically. There are things that we can do as injectors and things that we shouldn't do as injectors that assure us that our patients are unlikely to have filler migration or filler displacement over time. So I want to talk about three different factors, but before I do that, let's just see if you can see what I see from a lateral view. You can see here in the upper lip that the filler has moved beyond the vermilion border, and we have a little bit of a ridge coming across the upper lip like this. And on frontal view, often this looks like increased height. And when patients look in the mirror, perhaps they don't see this, but when we're assessing our patients in clinic, it's really important to also see them from the lateral view. And for me, this is very subtle, okay? I don't think that many patients would even notice this, but what we can see as injectors is the consequence of repeated treatments, the consequence of incorrectly identifying the lip compartments or using the wrong products, and that will then ultimately lead to migration of product or displacement. So that's characteristic in the upper lip. So now let's move to the under eye zone. And one of the other characteristic areas where we get chronic displacement of filler is the tear trough. And there are multiple reasons why this happens. The actual under eye itself can be prone to the same mechanical consequences that happen around the lips, i.e. the orbicularis oculis moving so much that there's a natural scrunching motion of the orbicularis oculi contracting, and any gels around the under eyes are subject to mechanical stress, which will slowly collate the gels into this nasojugal area, okay? So the filler is constantly being moved in this circular direction, clockwise towards the medial aspect of the under eye. So that's happening biomechanically anyway. But let's talk about the things that we can do both in the lip and the under eye that reduce the risk of this form of chronic displacement, okay? So first of all, number one is product selection. Generally, we know that higher G' products actually are more likely to stay in the compartments they're injected. And this is a little bit at odds with what the kind of products that we would want to naturally feel in the tissues, particularly in these soft zones like the under eye and the lips. So it's worth mentioning that there is a little bit of a balance here between the kind of gels that you would want to feel in those tissues versus the kind of gels that would actually stay put over time. So that's number one. Number two is respecting the anatomy. And we know in the lips, for example, that there are 12 anterior and 12 posterior compartments. And we also have a structure around the outside of the lip known as the vermilion border or white roll. And so understanding those compartments and the anatomy and then injecting in a way that doesn't allow for filler to move beyond those compartments is going to be critical to ensuring we don't have this displacement. Likewise, in the under eye region, injecting underneath the orbicularis oculi muscle rather than above the orbicularis oculi muscle means it's less likely to move over time. The third thing is avoiding undue trauma. So if we have these structures and we're injecting into them in the right way, we also want to inject them in a way that doesn't unnecessarily traumatize or put the filler at risk of moving into the wrong places, whether it's distorting the vermilion border or whether it's actually injecting above the muscle. And the final point is to avoid overfilling. So if we're injecting into these compartments, if we inject too much volume, then naturally those compartments aren't going to contain all the product in the lip, in the example of the lips, or in the under eye, injecting so much volume underneath the muscle that it naturally has nowhere else to go but above the muscle. So overfilling is another risk factor for avoiding these signs of chronic displacement. So in Emily's case, as we see in many patients who have had filler over the years, we have these characteristic signs, and I'm hopeful that with some hyaluronidase today, we can reduce the appearance of the unwanted filler. The second area that I want to treat with hyaluronidase is the medial cheek. And this is I would say, the most frequently overfilled zone of the face, particularly with patients that have had filler over time. And one thing to understand here is that the muscle, the zygomaticus major muscle, which originates from the zygomatic arch down to the modiolus of the mouth, this muscle actually acts as a septum that goes all the way from the skin down to the bone. And in doing so, it actually creates a lateral boundary for the filler. And biomechanically, when the patient smiles and this muscle contracts, it will bunch filler medially, and so it will create anterior projection in this part of the cheek. And so this is something that's been recently described as the transverse facial septum. And we have to be very careful in this medial cheek compartment to avoid overfilling, because at rest, things can look beautiful and treated and harmonious, but upon smiling, we can create too much anterior projection, which starts to look unnatural. So if you give me a really big smile and turn this way, what we can appreciate here, I think, is that there is some deep volume that is bunching up on smiling. And when we have too much projection in this area, it can start to look unnatural. It can narrow the gap between the lid-cheek junction, and the anterior projection can be quite significant, particularly in relation to a maxilla that's naturally receding with the aging process. And so we get these quite dramatic contours throughout the face, which in combination with a little bit of displacement of filler under the eye is really what we should be picking up as injectors, is something that we would like to naturalize. So my treatment plan is a multi-stage treatment plan, but today's focus is to reset back to baseline by focusing on these commonly mistreated areas to avoid filler displacement. What we're going to do first is we're going to use an ultrasound to see if we can visualize some of the deep volume in the medial cheek.
What we learnt in aesthetic medicine even 1 or 2 years ago is now outdated. Why? Because aesthetics is still a relatively new science, and the research underpinning our work, particularly our understanding of anatomy, has advanced significantly. Hello, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I want to introduce you to GEM, the Global Evidence Matrix. GEM is a dynamic, evidence-based framework that gives injectors a clear, consistent guide for safe, effective treatments, all grounded in science, not in corporate sales pitches. GEM combines clinical research, anatomical knowledge, and injector expertise, and it's always updated with the latest evidence. Think of GEM as your interactive map for facial aesthetics, guiding you through every step from technique to product choice. With GEM, you're not just injecting, you're working at the forefront of medical aesthetics. Join us in setting a new standard for safety and results.
Hi, my name is Max Greenfield. I'm one of the doctors here at Harley Academy, and I'm going to be doing a little bit of ultrasound now just on this medial part of the cheek to see if we can see any of that old filler there. It's sometimes a little bit more challenging when it's been placed a little while ago, and Emily, it's been a little while since your cheek filler, I think.
I think it was somewhere between 8 and 10 years when it's first started.
Fine, okay. Well, we'll have a look and see if there's anything we can see and target. So we're going to start over the medial cheek here. There we go. And what we can see just on this side here is the zygoma. So we've got the dermis, we've got our subcutaneous fat underneath there. We can just about make out the SMAS on the screen here. We'll have our deep fat and then our bone, which is that bright white structure there. And this is our lateral zygoma here. And as we come medially, we can just see it dropping off the medial zygoma towards the apex of the cheek, towards our deep fat compartments. Heading right down towards the piriform fossa on the left-hand aspect of this screen. And whether or not it shows up clearly in this camera, you can just see these little white black circles. That there is filler that's sitting probably a little bit more superficially than we would like for deep fat compartment treatment. And this could either be sitting in the SMAS itself, or in that space between the SMAS and the lip elevator muscles, that pre-maxillary space. But what I can't see is a huge amount of filler down here in the true deep medial cheek fat. So all sitting a little bit more superficially than we would like, which probably explains why it's bunching up a bit during animation. We'll have a look on the other side as well.
So what do you think, Max? Would we dissolve this by treating with a cannula or with a needle?
I think cannula in, again, between, so popping underneath the SMAS, but still staying in that pre-maxillary space.
Sounds good.
So let's have a look on this side as well. Let me just unfreeze that. Oh, and again, straight away. So let me start the zygoma so we can find where we are. So again, you can see this white structure under here. That's our zygoma. And you can see, actually, some filler over the lateral zygoma. So we've got our skin, dermis, subcutaneous fat. Here, this black structure is our filler. Then we've got our pre-periosteal fat and periosteum, this bright white structure. And as I come medially, here, this black structure here will be our orbicularis oculi muscle. Then as I come more medial still, towards the deep medial cheek fat compartment, these little circles, black circles there, that is all of our filler sitting within the SMAS.
Yeah, I think we'd say is that within layer 3?
I think it may well be, yeah.
Which is actually quite common for mid-face treatments, as we are learning on these ultrasound studies, that filler, unfortunately, is actually quite hard to place in the area that you intend it to. And there are various things we can do as injectors to make sure that the filler does end up in the target that we intend. But this is a good example of having multiple nodules of hyaluronic acid actually found within layer 3.
Very good. Brilliant. So yeah, as we suspected, where it is. Oh.
Thanks, Max. So where does that leave us? What we've seen here is not an unusual thing. I think that's really important to appreciate, is that there are thousands, possibly millions of patients out there in the world who have had filler injected. Both the patient and the practitioner have intended it to stay in one place, but either at the moment it's injected, it is displaced, or over time it is displaced. And so I think it will become more common and more regular for patients to come into clinics and be completely naturalized back to baseline. And I think this just reflects a lot of the learnings we've had as clinicians over the years. And I think as fillers, the new generation of injecting, the products we use, how we think about injecting will be far more specific, far more scientific, far more anatomical. And I think this is a reflection of how injections have been done over the last decade. The filler that Max has shown you exists actually in layer 3 and layer 4 of the midface. There is very little filler deep down onto bone, which means that if we try to dissolve that filler with a hyaluronidase deep down onto bone, we may actually miss it. The best way to treat and dissolve this unwanted filler in the midface is actually with a cannula. And so we're gonna do that. The specific anatomy of the compartments that we want to treat with retreat, we will cover in the next session. But for today, let's get on with dissolving some of that filler. The hyaluronidase we're gonna use, the dilution we're gonna use is a 1,500 unit vial divided by or diluted into a 5 ml solution of saline. We can also add a little bit of lidocaine in there. It could be 1 ml of lidocaine and 4 ml of bacteriostatic saline. And so that will give us a solution of the hyalase. And then we're going to use 1 ml of volume to dissolve roughly 1 ml of filler. So let's imagine that we're treating the lips. I'm going to use 1 ml of solution. That's 300 units of hyaluronidase. I'm going to use that around the mouth. I'm going to use the same again under the eyes. And then I'm going to use the same again in the anterior cheek. And so this will give us enough dilution. The saline itself is required to dilute the hyaluronic acid that's in the tissue, with of course the enzyme that's in there to actually break down the hyaluronic acid as well.